Good afternoon. We'll make a start for the sake of time. My name is Mai Krishnasamy. I am the Research and Education Lead for Cancer Nursing for the VCCC and also chairing Cancer Nursing at the University of Melbourne. And it's my real pleasure to be chairing this Monday Lunch Live session. I would like to pay my respects to the traditional owners of the land and who we meet today, the Wurundjeri people of the Kulin Nation, and acknowledge and pay my respect to their elders, past, present, and future. Before I go on and introduce and say something about the VCCC, I have, by pain of death, been asked to remind you that there are other sessions coming up for the Monday Lunch Live series, and we'll come back to this slide at the end, but a series of great talks coming in the next couple of weeks, and after we hear from Dr. Meron Picher today. Many of you I know will be familiar with the concept of the VCCC, an alliance of 10 organizations that has clinical partners, academic and research institute partners, and really the raison d'etre of the VCCC is to bring together and enable collaborations across different groups of people that would not have been possible without a vehicle such as the VCCC to enable interactions, innovations, dynamic conversations that can be best facilitated when a group of organizations is brought together, and in so doing, deliver outcomes to our patients in terms of their care and their treatment and research innovations that would not be possible through the infrastructure of single organizations. And that really has resonance with what we will hear Dr. Picher talk about today in the concept of thinking about how do we, through the incredible opportunity that we have as an alliance of organizations, share our knowledge and skills with each other, but very importantly out beyond our own context, and we'll hear a bit more about that. So without any further ado, it is my real pleasure to introduce our speaker for today, Dr. Meron Picher, who's a general and breast surgeon who's worked as a specialist in Western Health since 1993. Meron trained here in Melbourne before going to the UK, to the Royal Marsden Hospital, and has then come back here and has also worked as a senior examiner in general surgery since then for the Royal Australasian College of Surgeons. At Western Health, Meron is head of the breast unit and also head of the Sunshine Hospital General Surgery Unit, and also has some responsibility for quality and safety in the perioperative areas. Her research interests are wide, but she particularly has an interest in quality of life and survivorship for women who've had treatment for breast cancer. So today, though, quite differently, excuse me, she will take us on a journey to the northern coastal reaches of the island of Papua New Guinea. And it's here last year that Meron spent 4 months as a surgical mentor with the Australian Volunteers International. And in her presentation today, we're going to hear Meron compare and contrast her experiences of working with clinicians and clinical partners in PNG with those here in Melbourne. So Meron, welcome.
Thank you. So thank you very much, Mai, for your kind introduction, and thank you very much to the VCCC for inviting me to give this talk. I think it's really a great honour to be asked to speak at this forum, so I thank you for that. As Mai said, I spent several months in the middle of last year in Papua New Guinea. And that came about because I had an email from the College of Surgeons forwarding on a job advertisement from Australian Volunteers International, which are the old Australian Volunteers Abroad, if any of you remember that, which has been going now, I think, for nearly 60 years. But in essence, this job ad arrived in my email box in the middle of a fairly tedious Friday afternoon consulting where I was primarily dealing with the worried well, which is an important part of my job. And it sort of said they wanted someone, a supervising surgical mentor, Papua New Guinea, hours 8 till 4, Monday to Friday, no on call. And I thought, that sounds rather appealing. Anyway, cut a long story short, I went to WEWAC. And for those of you whose geography is similarly bad as mine, I will show you where WEWAC is. So I think you will, I'm assuming you all know where Papua New Guinea is. And if you look here, you've got Port Moresby. It's on sort of the bottom right-hand corner near the south. And WEWAC is right up here. It's up on this northern coast. It's not that far from Manus Island, which you will have heard in the news. And there was a volcano that went off not very far away, the Kadavar volcano, a few weeks ago. But this is WEWAC. Now, to get there, you basically fly from Port Moresby to Madang, and then that takes about an hour and a bit, and then you hang on the ground and drop off a few people, get a few other people on, and then it's about a 20-minute, 30-minute flight across the Sepik River, which is one of the major rivers and I think a fabulous place. I'll show you one picture at the end of that, to get into WEWAC itself. But part of the purpose of this is to show the sort of the size of the place. But basically, these are all mountains in here, so you can't really drive in. The transport's sort of pretty non-existent. So you can, really the closest medical support is Madang, and that's a plane trip away, or you can go in a boat, like a little motorboat, and I think from memory, I think it takes you 2 days, but it's pretty dangerous because people drown all the time on that. So that's really, for people from WEWAC, if they want better services than the WEWAC, they generally go to Madang, occasionally to Lae, but again, to get there, you've got to fly to Madang, Moresby, back to Lae, or you go to Moresby or somewhere else. But anyway, that's where I was, WEWAC. Now, in part of the advertising for this, someone said, you know, stories from paradise. Well, that wasn't my title for this talk. But when I spoke to one of my old colleagues, and I know several of you in the audience will know Trevor Jones, who spent a little bit of a time in his training, as did a number of Royal Melbourne trainees back in the 1970s time in Papua New Guinea. And Trevor said, WEWAC, paradise. Well, that sounds nice. And then I had a patient who was a retired anthropologist, and I said, look, I won't be here for the next few months because I'm going to WEWAC. And she goes, you poor thing. So it was a bit of a combination of both, really. But this is a photograph from the WEWAC Inn Hotel, which is where the group of other volunteers who were there in WEWAC would go and have a quiet beer on a Friday night. So I think this looks a little bit like paradise, and there were elements of it which were just gorgeous. So Papua New Guinea, population about 8 million, median age is 21, so they're pretty young. Life expectancy, 63. Just have a think about where Australia fits in some of those figures. WEWAC, population about 40,000 in the town, recently swollen by people coming from, they've evacuated from where the volcano was. But the WEWAC hospital, or the Borum Hospital at WEWAC, which is where I was based, is the main provincial hospital. And that services a community of about 750,000 people. These are the sort of plaques at the hospital. So some of you are old enough to remember Paul Hasluck. He became a Sir and was Governor General of Australia sometime after that. So the main hospital there was opened in 1962. And you can see that the Japanese government donated some money back in 1992. WEWAC's other claim to fame was it was where the Japanese air base was during the war. So there was a fair amount of Japanese influence there in the early 1940s. There's a really moving war memorial there, which has got great big coconut palms with names of servicemen who were killed there. It's a very, I didn't put that slide in because I didn't think it was relevant to cancer in PNG, but that's at Cape Wom. It was where the Japanese surrendered. So there's quite a long history with Japan. So one of the things about the hospital is that it's a little bit out of town. It's about 15 minutes on a pretty bumpy, pothole-ridden road from the town of WEWAC. It's on a very narrow peninsula, and you can see on the left part of the ocean with the palm trees. And if you look on the other side, the palm trees, that's ocean on the other side. So the hospital is long and narrow. Those of you who remember the old Repat hospital with sort of duckboards going down with wards on either side. A surgeon who'd worked there and done a little bit of aid from New Zealand said to me, Merrin, the critical thing to do is when you get into the ward, make sure they open the door at each end so that you can actually, as you're doing a ward round, you can see the ocean and the palm trees on either side. That was useful and good advice. So that's the sort of place where the hospital is. My task was really there as surgical mentor. And I discovered before I went there that basically the sum total of the surgical staff was 1 surgeon and 2 junior doctors. So this is Jenny. Jenny is a general surgeon trained in PNG. They have their own training program with rotations and exams. She's done what's called a Master of Medicine, which is following on their basic degree, which is done in PNG. And Jenny got her final qualification 2 years ago. She's a single mum with 4 kids. And she is the surgeon for the whole of the East Sepik province, 750 million people. So she's on 24 hours a day, 7 days a week. She has 2 junior doctors. This is Mabone and this is Bele, and they're wearing ties because it's Friday. So Friday you wear a tie to work. That's the tradition in Papua New Guinea. So it's dress up day, as distinct from dress down day. These are postgraduate year 3, and both of them want to be surgeons. So this is the sum total of the surgical staff for 750,000 people. So, yeah. So what about the health services in Papua New Guinea in general? This is a sort of hierarchy, if you like. They've got aid posts. I never actually saw most of these things. But in essence, that would be generally staffed by perhaps a community nurse. There are community health posts, which are places where there was potential for overnight stay. So these are out in the regions and the sort of the remoter areas. There are urban and regional health centres which usually have a medical practitioner. There are some district hospitals. Our closest one was Marprik, which was about 3 or 4 hours up the highway, which used to be a highway which went somewhere, but the road's so bad it actually doesn't go anywhere. And then with rain and landslips and no money to fix it. But at Marprik, they could deliver babies. I don't know what else they did. They probably put plasters on, I think. And then we were the provincial hospital. But the main referral national hospital is in Port Moresby. There's quite a bit of health service that comes from various church organisations. The Catholic Church is very big in Papua New Guinea, as are the Seventh-day Adventists. They're the 2 main groups. which are heavily involved in education and care. So my experience in PNG was, you know, I feel as if, you know, I really only scratched a tiny little bit of the surface. But I've put this photograph in. This is what's called a banana boat. And I presume it's a banana boat because they transported bananas, which is one of the, I think that's why they're called banana boats. They don't really look like bananas, but they're basically a long, narrow boat with an outboard motor, which can carry about 20 or so people. And this is from one of the islands. And so because of the little islands, or indeed people who are coming down the Sepik River, they would travel in a boat like this. And you can see someone's off to the hospital or the clinic because they've got their arm wrapped in a sling. But this is the sort of way people get to hospital, and it's very challenging, just the geography. And I know some of you have just had lunch, but I'm a surgeon, so I tell terrible stories. There was a lady, a 17-year-old girl, who presented to our hospital who had an injury. She had a spade injury to her foot. So she'd basically almost amputated her foot. So after 2 weeks, this foot was pretty, the forefoot was pretty dead, and it had taken her 2 weeks to get from where she lived to the nearest hospital facility. So, you know, I was complaining that I spent 2 hours in traffic last Friday afternoon getting across town, but to travel for 2 weeks with no treatment, she did very well. But that's the sort of environment that I was practicing in. It was really phenomenally useful and helpful for me to actually get out of the town, which is a fairly dusty, nondescript sort of place, to some of the villages. This was up on the Sepik River, and gives you an idea of the sort of very standard village accommodation. It was a group of us volunteers up there, so they actually put up a little shower for us, because otherwise everyone just washed in the river. And if you look very carefully in the corner over there, hold on, there's a sort of bush hut, which was the toilet. But this is the way that the majority of locals live. The villages had a little bit more, but this place had no electricity. It had, we sort of had, I tell a lie, they had some solar battery type electricity. So you'd put out the solar panels so that you could have a little bit of light, but it really, there's no running water. They have to row across the river to get to a source of water. So they have that in big plastic buckets and things. So here we are on the surgical ward, one of the surgical wards at the hospital. Wewak Hospital had about 100 beds. About 40 of those were surgical. From a point of view of what other staff, there was a obstetrician gynecologist, there were 2 physicians, there was an emergency department which had 1 doctor who had been dismissed from the surgical training program, I think because of bad behaviour with alcohol. And the rest of the staff was with what are called health extension officers. Now, a health extension officer is someone who has done a 4-year degree training. To me, they fitted a bit more like probably ambulance officers here. So they've done, they're trained to the extent that they can diagnose, treat and prescribe simple conditions. So they had the license of prescription, but they were the people who primarily funded the outposts. It's not funded, they ran those places and then would send people into us. So they would do the first aid, they could prescribe antibiotics, they could manage straightforward deliveries, they could sort of put on the odd plaster or manage the odd wound into various extents. And so there were a number of health extension officers who would work in the hospital as well as assistants. So they were sort of like staff grade lower people who could, you know, they'd put in drips and do various things. But the points to see here, if you look up, you can see the holes in the ceiling, so the rain would come in. There are fans there that would spin the air a little bit. You can see out the door at the end of the corridor. You can't see the ocean through that, but that's what was out there. And you can see that there are various holes in the floor. So there were 4 wards like this which were surgical. And whilst I was there at the hospital, they were building. Has anyone ever worked in a hospital where they're not building? I defy, maybe they're not building here. Are they building here? But they'd had a loan of 80 million euros. Not quite sure how they're going to pay that back, to actually upgrade the hospital. So there's some Austrian company that goes around the world putting in new kit hospitals. And they've done that in Goroka, apparently, not that I got up into the Highlands to see Goroka. And so I had the privilege of being there for the opening of some new surgical wards. So you can see that we did actually, I had nothing to do with it, but we made some progress whilst we were there. So this is the nurse's office. And although at superficial view, it looks pretty shocking, they had an urn, so they could actually have a cup of tea. There is on the shelf a box of totty, which are little savoury, salty biscuits to keep people going. There's a hand basin which says, "Please wassum hand belong you," which is pidgin for "please wash your hands." And there's a bit about the moments of hand hygiene, I think, up above there as well. And somewhere for people to store the policies and procedures and their personal items. So it's functional. It's sort of old and tatty, but it sort of worked. So what did we have available to us? The short answer is not a lot. I had and have done various trips in what I would call interesting places in the past. And I have always been very aware of what we have here in Melbourne and Australia, and in terms of, you know, what we just completely take for granted. But it was very basic. In terms of investigations, there was an X-ray department that could do plain X-rays some days, quality of which was not great. We couldn't always get a plain X-ray. Someday they just ran out of film, or there was no water because the water supply was irregular. And the problem with printing off X-ray films is that you need to have the machine cooled at a certain temperature, and when you're in a tropical environment, you can't do that. So there'd be days where we would have no X-rays. Where there was an ultrasound machine, which was used by the obstetric department, we would occasionally try and use that, but it gave very grainy pictures, and then there'd been no training provided for anyone with that. So Mabone and Bele weren't bad using it, and they could see things that I couldn't see at all. From a point of view of biochemistry, yeah, we usually couldn't do electrolytes. I think about twice during the time we were there, we could do liver function. We could usually do a hemoglobin. We could usually do a cross-match, but they would run out of reagents to test for HIV and hepatitis. And so if they ran out of reagents, then we just didn't have any blood, because they wouldn't administer any blood without it being tested for HIV and hepatitis. And the rate of blood which was not usable because of that was about 20%. But the critical bit, if we're getting onto cancer, because I know this is what I'm meant to be talking about, is that there was no histopathology service. There is no cytology service. So Jenny, who was the surgeon I was mentoring, would do an operation and do a biopsy and put it in a pot with some formalin, and we'll do that. And then there was this whole bench full of fairly scrappy looking bits of tissue waiting to be sent to Port Moresby. And it sort of never really went, but there was this pretense that it would. You would write some clinical notes on a form. I'm not very good at that sort of pretense. I'm saying, what is the point? You are never going to get it. What are you doing? But I think they sort of lived in hope. But there was one woman who had an oral cancer, and she was someone who clearly had more money and wherewithal than most. She was larger, both in stature and body mass index than most, and where I was, that was generally a sign of more money. And she'd had some lichen, I want to say lichen planus, have I got the right word? Like leukoplakia, sorry, I'm not an oral surgeon. She'd had some leukoplakia which had been monitored in her mouth, which is precancerous. And she'd come along because she thought it was a little bit worse. And under local anaesthetic, we took a couple of little nips of biopsy, so tiny little specimens, and sent that away. And because she had some good political connections, we were able to send that specimen, or she was able to get it to Port Moresby, to the pathology department at Port Moresby, where there is a pathologist. It took us 7 weeks to get an answer. Is this cancer or not? And that was with someone who had political connections and wherewithal. So when we come to talk about cancer, you know, we're all being brought up, you need to know exactly what it is, you want to know what the molecular markers are, you want to know all these things so that you can target therapy. We couldn't do any of that. And this is a country that is somewhat, you know, we're seen as the big brother in a sense, and although that's a little bit very patriarchal and what have you, there's clearly something very wrong, I think, from a moral perspective with what they don't have and what we have. So why is it like this? And again, I'm going to, I don't much like it when people read slides, but I will read this one because I feel like it. This came from the internet. I think it was one of the WHO reports, but it basically says that different funding sources result in different plans with inconsistencies that make implementation difficult. Bottlenecks in financing result in delayed payments, uneven spending patterns, funds not reaching frontline service delivery. Although most provinces now receive increased health function grants, resources are still insufficient to cover the minimum cost of basic rural health services. Provincial governments prioritise funding the costs of administration over service delivery. This results in persistently low spending by provinces on recurrent operational health costs, such as medical supplies, distribution of medicines, facility maintenance, fuel and travel for outreach patrols and supervisory visits. So that's all pretty dire and depressing. I was there during the election last year, which was very entertaining, and I can tell you all about that perhaps another day. But again, the government decided in its wisdom that instead of funding the district hospital, they would fund the district, so the health administration, so that they could actually put it out to all the various areas, but they didn't actually provide any money. So there was no money. The other thing I meant to say in services is one of the great advances of my medical career is the availability of the internet. So if you're not sure what to do, you just look it up on the internet or you YouTube it or what have you. The hospital had no internet. Mobile phone coverage was patchy. We could get 3G on a good day, but there wasn't any at the hospital. So the person who I was sharing a house with was another volunteer from Sydney, and her job was in HR. And one day she came back and said, I've worked out a bit about the pay system because the nurses get paid depending on their shift allowances things. So they have to put in, if you're doing shift allowances, but to actually access the pay which comes from Port Moresby, they had to enter it in on the internet so that they'd get properly paid. Well, the problem was there was no internet, so that the staff in HR had those little scratchy cards that we used to have to get your top up. And so they would be scratching a card to put the number in so they could get enough internet to actually get the person paid. So that the smart nursing staff were turning up with their scratchy card to the person in the pay office so they'd actually get paid. So, yeah, challenging. Okay, let me tell you some more positive things. So this is the sort of what the new structure, the new wards looked like. As I say, God knows how they're going to pay back the money, but And this was sort of the day of opening when we moved in patients. We didn't actually have any running water in the ward when the day we moved in. We didn't actually have any telephone when, sort of internal telephone when we moved in, but we did have some balloons and some very happy patients. There were 2 operating theatres, and they were basic, as you can see, but they are very functional. We've got an anaesthetic machine, we've got suction, we've got diathermy using reusable stuff, we've got reasonable theatre lights, we've got a spare oxygen bottle, that was always a good sign, and scrub sinks, one of which didn't work. The buckets are there for water so that if the water was off, you could actually use that little scooper to sort of scoop to wash your hands. So let me get on to cancer. These are some data from the World Health Organization from 2014. And you can see the major cancer types that are there. As I say, the data is pretty much non-existent, because if you actually haven't got histology, you haven't got imaging, you're really not going to know. And a lot of people just aren't going to turn up to hospital or what have you. So classification is just, I would say, completely unreliable. Whilst I was in WEWAC, I saw a number of women with breast cancer. I saw a number of patients with head and neck cancer, oral cancer, several rectal and anal cancers, and I saw one woman with a very locally advanced sarcoma of her thigh in that time that I was there. They were the main ones that I could see that were obvious. And I remember a gynaecologist coming out of theatre one day saying, you know, just shaking his head, he'd seen another terrible locally advanced cancer of the cervix on an EUA. So they saw quite a lot of cancer of the cervix. And because I was working in the surgical field, I wasn't looking at people with lung cancer, but I dare say there were a reasonable number of those. These are the mortality figures that the World Health Organization has got. And again, if you look at that, it's not surprising that cancer of the cervix is high up on the list. And there's a reasonable amount of liver cancer, and I think that almost certainly reflects hepatitis, is my assumption, although I didn't really see that. So as I've said, cervical cancer is the leading female cancer in Papua New Guinea. And again, how they manufacture these statistics, I don't know. But to me, the compare and contrast, 26.7 per 100,000 with 7 per 100,000 in Australia, with a significant number of deaths. Oral cancer is the #1 cause of cancer deaths in men, and with a very high incidence. And the reason for that is betel nut, which I'll talk about a little bit more, but the particular thing about betel nut is you chew it and it gives you a bit of a rush. The locals sort of say, oh, it's just like you having a cup of coffee. I don't really think so. But it does give you the very obvious red stained teeth, the telltale sign. So if we think about cancer, or if I think about cancer, you need to remember I'm a surgeon, so keep things very simple because I can't understand other things. So for the way we treat cancer primarily is with an operation, we use radiation treatment, and we use various drugs. And I commonly say to my patients, we know that we get the best outcomes when we use these combinations of treatments. That's when we get the best outcomes for many cancers. It's not one modality, it's many modalities that we would generally use. So if I first go to surgery, the challenges with surgery in WEWAC and in Papua New Guinea in the Broad is that the majority of people will present late. They don't have access to doctors down in the clinic, and they're only going to go there if they can actually get there. Now, to get there, they've either got to walk or they've got to get a lift with someone, And you've got to assume that they've actually got a vehicle, they've got petrol. There are PMVs, public motor vehicles, which are rickety buses that you pay to go, and you might catch a bus from one spot to another. And really that costs money, which you probably got to get from other people in the village to enable you to travel to a medical facility. And then you need to have somewhere to stay when you're there. And hopefully you've got some Wontoks that you can stay with or who will look after you. So to me, the village has to sort of go, yep, we're happy to all pump together to give some money to Fred so that he can go to the hospital to get diagnosed and treated. So late presentation is the norm. And so of the women I saw with breast cancer, many of them had metastatic disease at presentation. Malaria is totally endemic. Tuberculosis is rife. And malnutrition is not uncommon, particularly see it in the kids. There's lots of endemic worms. The first thing you do if they're anemic is you just worm them, really. So, and true in adults as well. And you can understand if you're the one surgeon for the province of 750,000, you're dealing with everything. So you're dealing with abdominal surgery, you're dealing with trauma. 25% of our workload was trauma from bush knife injuries, which are machete wounds, compound fractures, major nerve vessel, tendon injury, you know, you name it, Jenny could do it. People with an axe wound to the head. Perhaps we won't operate on this one. But you've got limited experience and expertise. So we had in Madang, which was our nearest town, there was a fellow who, again, was a local who'd done some training in Australia in ENT and head and neck surgery. He was a local person and he came and spent a week with us doing some head and neck cases. But there's very limited expertise, certainly locally. There's some more down in Port Moresby. I don't think anyone uses pethidine for analgesia anymore. 50 milligrams is a very small dose, and it was given strictly 6 hourly. 11 a.m., 5 p.m., 11 p.m. and 5 a.m. was when you got your pethidine after your laparotomy. I must say that the patients were very stoic. They didn't have high expectations, and they'd often been putting up with a lot for a long time. But we did run out of oral analgesics for a time. And the director of pharmacy put out an edict which said narcotics will only be available on Wednesdays between 10 and 12 or something. And I haven't got a photograph of that, but I didn't put that in the talk. But to me, just the craziness. And so with patients who were diagnosed with cancer or clearly had a terminal disease, I had one morning in particular, and Jenny sat down with, when you go into hospital, you have to bring a carer with you, because the carer will actually organise your food, do the hygiene things, whereas the nurses will look after the drip and the tablets, but they're not actually doing any personal caring. So you have to have a carer, otherwise no one can look after you, or you're not going to get looked after. So Jenny called a patient. We had several patients. That there was one with the lady with the big sarcoma who just had this horrible, smelly, bleeding thing. She was grossly anemic, and we could do nothing under those circumstances. And so calls in the husband. You know, she wasn't very old. She was only sort of 30 odd or something, and said, you know, yes, your wife has got this. No, we can't do anything. You need to take her home to the village to die. And he'd go, thank you very much, doctor, and would walk out. That would be the counselling that would happen. And, you know, to me, it was astounding. I'm sort of, you know, you put your very senior, I'm very strong sort of professional face on, and you're thinking, if we were having this conversation in Melbourne, there would be all sorts of support people around. There would be all sorts of ways we could assist. But no, this is, you go back to the village where you will be looked after. And so to me, you need to have, this is where the village is so important, because everyone in the village will have that expectation that they will look after each other. So again, it sort of reminds me that, you know, you want a few friends. You don't want too many enemies in the village. You know, you really want people who will support you in your health journey or what have you. But to me, it was just the contrast in that space was phenomenal. So what about radiation? Radiation is a very important adjunct part of our treatment for cancer, but it's critically important for people with advanced disease and metastatic disease. That's where it really comes into its own. And so Papua New Guinea desperately needs radiation. And they have had a radiotherapy facility in Lae, which has been there sort of, I think probably again since the about 1960s or thereabouts. So that's really where the cancer, that's the Peter Mac of Papua New Guinea. But unfortunately, they currently have no radiation. So there is no radiation available in Port Moresby. There is currently no radiation in Lae. So John Niblett may well be known to some people. I'm not sure where he was originally from, but he practiced in Perth for a long time, from WA. He had polio, so he actually practiced from a wheelchair. And he'd been so very much loved and would give various bits of chemo, which I'll talk about, but was able to do sort of post-radiation for people who'd had resections for head and neck cancer and some palliative treatment. But currently there is no radiation available. They did get a Cobalt-60 machine 6 years ago. Now, I know almost nothing about radiation, but this is a sort of old variety which is used for superficial type things. It's not anywhere near what could be used. And one of my sort of thought bubbles whilst I was there and coming back is, could we actually send some rotating radiotherapy people there to work with the radiotherapists? Because I think there are some radiotherapy technicians who could drive the machine to do stuff. But my spies say, well, look, actually none of the current radiotherapists know how to drive this because it's too old in terms of the technology. So that's the very sad story about radiation. What about drugs? Well, methotrexate, good old-fashioned methotrexate, we could get that. And so a number of the people I saw in outpatients with oral cancers were taking methotrexate with reasonable stability of their tumours. Having said that, I think some oral cancers are probably pretty indolent, but at least you felt you were doing something without causing too much trouble. So that's a big tick. CMF, cyclophosphamide methotrexate 5-FU, was sort of used when I was a junior registrar as the adjuvant therapy for breast cancer. And in theory, we could prescribe it. In fact, we had someone with, you couldn't get histology of the breast cancer. You couldn't get the receptor status of the breast cancer. But if they hadn't done well on tamoxifen, which you'd given as best guess, well, perhaps we could give them CMF. But we went to the store and really it was just that all the drugs that was there were out of date and they had no idea when the next lot would come in. So that really didn't happen. We did have tamoxifen, but the general drug supply was intermittent. The health department put out tenders for the supply of drugs. They'd had an agreement with the Australian government, so it came under an Australian government umbrella, but several years ago they said, no, we'll do it ourselves. So they put it out to tender, and they gave the tender to a company that doesn't actually fulfill the international regulations for, what you're getting is what you're getting. And it wasn't even the cheapest quote. So the local clinicians are pretty unhappy, and the antibiotics come in different colours. Are they getting the same drug or what have you? So lots of unhappiness around the medication. So what do you do? Port Moresby's got CT scan. They have a much greater number of specialists. There is a private hospital there as well, although the doctors at WEWAC seem to think that you got better care in the public than in the private because there was a little bit of money taking. And there is some oncology service. It is possible, if the province has money, to fund a patient to get there, but basically there wasn't ever much money, and you'd say, oh, maybe next week, maybe next week. We had a guy, young bloke who was about 20, who had recurrent epistaxis nosebleeds from what was an angiofibroma in his nose, which apparently is common in that part of the world, and he was requiring transfusion. We had him in, and we were waiting to get him to Moresby so that he could actually get a scan and get done. But he waited sort of like 6 weeks just sitting on the ward. There's no incentive to get anyone out of hospital. It was very stressful for me when I'm like, get out, get out, get out. You know, what are you worried about? No. So a number of people can self-fund, but that's unusual. The ones who've got money would often go to Philippines, Singapore, occasionally India. Not very often Australia. I think we were too expensive. Supportive care. A critical part of cancer care is supportive care and or palliative care. We had pretty much nothing. When these people with fairly horrible cancers were being sent home to die, we could give them a 2-week supply of oral morphine. I'm not quite sure what the dose was. I wasn't brave enough to look at that or argue. And to me, the question was, were they going to be able to get any morphine locally at the aid post? And the answer is they might not. So I think that's pretty dire. This was a gentleman who'd had an abdominoperineal resection for a rectal cancer and with an end stoma. And we had a sort of box with a little bit of a selection of stoma bags that someone had sent in the past and would occasionally send some things. But basically it was often a plastic bag taped on with some tape. And I think modern stomal appliances have revolutionised the care of people who require them. But I mean, this guy was, you know, probably a bit better off than most, and he was really, you know, very proactive in what he's doing. But if you're thinking about you're in a place where electricity supply is intermittent, the water supply is intermittent, flushing toilets are a luxury that you might have in town but not anywhere else, to have to manage with a plastic bag is pretty dreadful. So what about prevention of cancer? Well, yeah, betel nut. It was probably one of the major industries in the East Sepik was betel nut. Every little market stall was selling betel nut, and you know, there are various ways of eating it and doing it, but basically everyone chews betel nut in the East Sepik. At the hospital there was a sign saying anyone smoking or found chewing betel nut will be fined 20 kina, but that basically no one ever policed it. This is the doctor's office in theatre, which is blocked because of betel nut spit. And the particular thing that I found amusing was, you know, I presume you can read that to spit buoy, that's betel nut. Don't spit, pour anything or even open the tap. They're still awaiting the hospital plumber, and this was 12 months old. So no one really could be bothered fixing it because they fixed that, well, it just needed to be sort of redone. That's some betel nuts, fresh betel nut spit, which was sort of everywhere. And again, if you think about tuberculosis and spitting, you know, it's really not a great combination. So the only people who didn't chew betel nut were the dentists. They were the only people who really didn't, because everyone else did. Cigarettes, we know that tobacco is a major cause of cancer around the world. Not such a big deal there, I think mainly because it was sort of financially out of the reach. So you didn't see people smoking heavily. Immunisation is one of the great things that we can do to prevent cancer. But because of the intermittent funding at aid posts, infant immunisation is patchy. I think one of the few lasting impressions I might have made was whenever there was a child in the ward, I'd say, can we check their immunisation status? Have they been fully immunised? Have you checked it? So that we could actually get them up to speed. Hepatitis B is part of that. We had a case of tetanus whilst I was there, and I've always said I never want to see a case of tetanus because So when I'm going around the wards at Sunshine, have they been immunised? What have you? I tend to say the same things over and over again. But this boy had been partially immunised and had tetanus, so they did a grand round on tetanus. And so I asked the question, well, you know, where are you all at with your, when did you last have a tetanus injection, I said to the room. So there were lots of people looking at the floor, because clearly most of them really had no recollection or memory of when they had. And then, so privately afterwards, I asked Jenny and the two boys, I said, well, what about hepatitis B? No, never been immunised. And you sort of think, these are the people who are the medical leaders, and if they aren't doing it, I mean, could they access it? You know, to me, that's sad. As I said, a significant percentage of the blood was not able to be used because of Hep B or HIV. A papillomavirus vaccine is available in Port Moresby, but it's clearly not being, you know, my guess is that you need people who know that it's available and have got the financial wherewithal. And to me, that's, in a country with such a high rate of survival, I mean, the challenge of immunisation is we mustn't underestimate it. It's sort of getting to the places, getting people, getting them to understand, because their whole idea, again, gross generalisation, that there are totally different health beliefs that are there. You know, disease, people would come in and they say, the reason I've got this is because the sorcerer in the village put this upon me. That's what's wrong with me. It's not that I need an operation. Or a spirit pushed me off the balcony. That's why I'm a paraplegic. Okay, it's different. So to me, you can't just go in and automatically immunise people. We like to think that that's the right thing to do, but we have to get there by understanding their belief systems. Screening, well, screening is one of my special subjects and beefs. The dentists would often recognise the early signs of oral cancer, but as I said, access to diagnosis and treatment limit effectiveness. There's a mammogram machine in Port Moresby, but I don't see much point in diagnosing something if you can't adequately treat it. There is a cervical screening program, which I think probably gets intermittently funded and done so that it gets into parts of the community. But just the logistics of bringing that in terms of remote areas are really, to me, it's pretty hard. So what can we do? What should we do? I spent, as I say, several months cogitating, thinking, wondering, what is it that we can do? Because it is really a very whole different system. And after I'd been there a while, I sort of could cope by saying, really, this is a parallel universe. All the rules are different. You know, there was always an excuse why you couldn't get an X-ray. The water was off, the power was off, the person wasn't in, the person was off sick, there wasn't anyone on the roster. You know, they had to go and visit their sick relative. You know, there was always an excuse for everything. And so to me, it's really about understanding that there are different rules in different places. But I think there are some things that we can do. I think that there is opportunity to support clinicians from the Pacific in general and in continuing education. And I know from surgeons that they are encouraged to attend our meetings, and there are various scholarships to do that. Though our disease systems are so different to theirs, the question is, how good is that? And there are certainly plenty of people who, clinicians who will visit Moresby to work alongside and be part of that. So it's clearly there's a limited amount you can do on a short-term visit. The commonest question I got asked for the first month was, how long are you here? Because clearly people come for short, quick visit, do a quick first aid and get out. And that does something for those individuals, but in terms of what legacy do you leave in that period of time? It's clear that it's cheaper and easier for doctors in Papua New Guinea to be trained elsewhere than Australia, and I think that's pretty sad. Though it may be culturally more appropriate for them going to places like India or Singapore. from a disease point of view, and certainly the regulations are a whole lot easier for that. I do think they urgently need radiotherapy. I know the International Radiation IA, I can't remember what it is, but they are sort of aware and looking at it in terms of providing radiotherapy in developing places. But I think given that they've had a radiotherapy facility and they've had local people trained, they're very smart, they're very industrious, they really want to help their community. I think there are ways to make that happen, but that will require a significant investment of money. And in light of current organisation in PNG and Moresby, I don't know that that's going to happen in the short term. I do think we need to lobby for targeted aid. We need to work against corruption everywhere at all levels, and we need to assist with economic management. I do think there are opportunities for partnering with individual people. So when I emailed Jenny before I went there, I said to her, look, because again, she hadn't been told that Australian volunteers were recruiting someone to come and support and mentor her in this place. You know, it was, and you know, I sort of thought that's pretty threatening, really, someone coming in. So I emailed her and I said, basically, look, I'm a nice person, I'm coming, I hope we can be friends. Is there anything you want to, you know, what sort of stuff are you doing? She said, we see lots of trauma, can you please bring an orthopaedic drill? And I thought, oh, okay, because I haven't done orthopaedics since I was a registrar a very long time ago. But I managed to get a second-hand drill from Footscray, which was surplus, and we were best friends as soon as I gave that. And so, to me, I've managed to send up some old stoma stuff as a box. Having said that, I posted it there, and it got stamped with some sort of import customs tax to sort of go. You know, it's the crazinesses of some of those systems. But, you know, there are those sorts of things. You know, can we get an agreement with pathology providers? John Mawa, who was the head and neck surgeon in Madang, had an agreement with Cabrini Hospital, and I think that's probably via Divine Word University, which trains in Madang, has connections with Cabrini, and so they have an agreement whereby he can post a specimen there and they will give him some pathology results. I've discussed that with Dorovich at Western Health, and they're in principle agreement, but at WEWAC, can they actually work out how to get a specimen into a post thing and spend the money to get it to me so I can give it to pathology? And that's clearly, you can do it on an odd one-off, but that's not a very sustainable thing. But there are ways we can think about that. I would like to engage with colorectal support groups to say, can we actually work out ways of getting stomal therapy equipment? Can we use that? Can we use our connections? Use our connections such as with Rotary or Lions or those things. Rotary is big in Papua New Guinea. But more particularly, really, I think what I would hope to do today is to just spend a moment reflecting on what we've got. And, you know, I spend a lot of my time complaining about a lot of things because things should be better and could be better. But you know, we are so well off. And one of the things I keep saying to people when they're coming to me with their various ailments or concerns about things, I say, look, it's Melbourne and it's 2018. We've got so much that we can do. You know, we're not in WEWAC worrying about the internet. Emma, who I shared a house with for several months, would occasionally say, Merrin, we've got the trifecta. We've got power, we've got water, and we've got internet. So that would be sort of usually a good day when we had all of those things. So I'll just leave you with probably one of the nicest photographs I took. This is the Sepik River. It's at dawn. It's taken from the opposite way that I took that house. And it just goes to show what a glorious place Papua New Guinea is. But thank you very much for listening and your attention.
Thank you very much, Merrin. For those of you who know me, it's not often I'm lost for words, but I'm not quite sure what to say other than the fact that I'm ashamed that I was complaining of being jet lagged before I got up to talk earlier. That was incredibly powerful, and I think we would all agree that it is something incredibly important that we hear about. We've got some time for questions. Does anybody have anything you'd like to ask? I've got something to get going if people are thinking. And I might start while people are thinking. The question that comes to me is, how do you come back and settle back into work after you've done that?
Look, it's difficult, and I really made it very difficult for myself because this got organised in about November, December. It was sort of happening, but it wasn't actually confirmed until end of March or early April because of registration, and bureaucratic systems in New Guinea don't work quickly. But I'd agreed to go with an old friend travelling to Europe in October last year. And so when I said to her, look, I'm going to be going to Papua New Guinea, she said, are we still going away? I said, yeah. So basically I came back at the start of September, and I had about 3 weeks. And then I went to Croatia for 2 weeks on a holiday. So the difference between Europe and Croatia and Papua New Guinea was just astounding. Yes, I think it was difficult because it was so different. But again, I think I come back to parallel universe. It was so different that it was so nice to sort of turn on the shower and the water would come out. You know, it was so nice to have fresh and good food available. It was so nice to be able to pick up the phone and talk to people. It was a bit hard to be polite to patients who were complaining about first world problems. Yeah, it was a bit difficult, but it almost now seems like a dream as I'm looking back at these pictures. But this is the real world. We're living in crazy land. We are so privileged in terms of doing things.
Does anybody have? Yes, thank you.
Well, with the trillion problems that they already have there, to cap it all then with what is 120 million Australian dollar loan for that hospital, even today in Australia, 120 million would produce something. I'd say more than what they have for that money. It must be a colossal amount of corruption.
Yeah.
Aggravate everything even more.
Yes, again, it's very much who you know and who's actually the current governor of the province and all those sorts of things. And I still don't understand it, because the natural wealth of PNG, you know, when you consider the amount of mineral and oil and stuff, and we mustn't forget the environmental effects of some of those things, but clearly they haven't been able to capitalise on that sort of money. You would think sort of intrinsically they've got welfare, but it's sort of evaporated.
Something wrong somewhere else.
Yeah.
Thank you. We'll just take one last question. Hi.
Do they have antibiotics at all?
Oh, antibiotics, yes. We would give everyone chloramphenicol, penicillin and gentamicin, I think. Everyone just got that combination regardless. We didn't, microbiology was, yeah, no, we didn't have anything we could culture. There was a Pseudomonas was diagnosed by the smell. We could do films for malaria, and they could do a Vidal test for typhoid, but basically chloramphenicol and penicillin were the mainstays. So antibiotic resistance. I did try and get them doing hand hygiene with some hand rub. That was another thing I tried to help with.
Thank you, Myrna. I'm aware of the time, although I must admit, when I saw the image with the curtains draped over the string, I did have visions of the infection control nurse at Peter Mac running through my mind. I don't know if Susan's in the audience, but I think that's been an incredible